Bismillahirrahmanirrahim. Dear students, I am Professor Dr. Akmal Alaeeq from the Pediatric Department at Akhtar Saeed Medical College. The topic for today's discussion is again in the subject of hepatology, and that is chronic liver disease and hepatic failure in children. In the previous talk, we have discussed the important subject of acute hepatitis, and now in continuity we'll be discussing the problems of chronic liver disease and hepatic failure in children. Again, I would like to give you an outline of the objectives set forth, that why this topic is being taught to you. First, I want all of you to understand and appreciate that chronic liver disease is very important for children. It has a large burden of disease as a morbidity and mortality, and should be learned by all of you. There are a number of underlying etiologies, morbid condition that ultimately produced chronic liver disease, and they are different in different areas of the world. So what are the clinical features on examination? What are the essential investigation required to make a diagnosis, and other modalities of treatment for diagnosis and treatment? Now, how should we treat them? There are different ways and means how we can manage these patients and how we can prevent the underlying disease process and stop its progression. Of course, chronic liver disease is not to be taken as a mild disease. It progresses and continues to cause further liver damage. So there must be a big role played by the preventive strategies to avoid long-term sequelae. And now finally, this is not a limited disease to just few percent of the population, but rather it is estimated that the chronic liver disease is now a big public health issue these days, especially in a developing country like Pakistan, and should be learned by all and practiced, the preventive strategies. Just to review why liver is a vital organ. There are so many vital functions of liver. It has a number of metabolic functions like water metabolism, glucose metabolism, carbohydrate metabolism, amino acid metabolism, fat metabolism. It has a number of hemopoietic functions, like it was a main organ of the synthesis of blood in the fetal life. But then the role decreased, and now under condition of stress, liver can still assume the role of a hemopoietic organ. Liver is a very important excretory organ of the body. It helps in getting rid of so many waste products of metabolism. Without a proper liver functioning, it would be not possible to get rid of them. Similarly, with the passage of time, so many toxins are coming in contact inside the human body, from outside, from inside. And the liver is the chief site of detoxification of these waste products and the toxin. Otherwise, we will be affected badly by the absence of the removal function of the liver. I just mentioned that liver is a very important function of the liver. It has a very important role to play in the blood clotting. It is a main organ to produce bile, and then there is a bile excretory pathways. There are so many toxin and drugs which are metabolized inside the liver. They are neutralized, and then they are sent as excretory organ of the liver, excretory function of the liver. Liver simply eliminates and detoxifies number of substances called hormones, endotoxins, otherwise they would cause harm to the baby. Liver is a very important source of immune mechanism in the body, and it resists infection. And nature has given liver a very important ability to regenerate. That whenever there is an extensive liver damage, the liver cells, they start regenerating. The liver cells, and liver is again an important organ where it helps to store glucose, iron, vitamins, minerals, blood, and so many things. So all of them ultimately end up that liver is a very important vital organ of the body. Now coming to the subject, and that is chronic liver disease, CLD. Let's review the situation from a public health point of view, from the community health point of view. It has been estimated that in Pakistan in 2019, there are 15 million cases of chronic hepatitis, around 1.5 crore. We are around 21 to 10 million. So, among chronic hepatitis B is around 5 million, and chronic hepatitis C is around 10 million. So, it has been estimated that around 8 to 10% of our population has come in contact with one of these two viruses, chronic hepatitis viruses. A very important figure. And one estimate from the hospital data indicates that around 23,700 deaths were noted in year 2016. Coming to long-term morbidity, the various hospitals are reporting that the mortality from the liver cancer cases has almost tripled in the last 10 years. So that is showing you that chronic liver disease has already become a very important public health issue, and it is expected that this trend will continue in near future as well until we take preventive action thoroughly. Now, what causes chronic liver disease? Is not one disease, but a number of underlying primary diseases end up as chronic liver disease. I give you some of the example. Now, these are the causes in children, especially in a country like us. Say, problems of the newborn in which there is neonatal cholestasis. There is limited, restricted biliary flow with secondary liver cell damage. Say, I give you an example of neonatal hepatitis, biliary atresia, choledochal cyst. All of them may end up as biliary cirrhosis and as an end-stage liver disease. Then, as the age advances, children get infected from hepatitis B and C, and then it continues. It continues, persists as chronic hepatitis, and ultimately ending up as chronic liver disease and hepatic failure, and sometimes as liver cell carcinoma. It can be a drug-induced liver injury. It can be hepatitis as a result of autoimmune phenomena, and then might continue as liver failure. There are conditions in which there is venous flow obstruction, occluded venous blood flow, vascular issues like Budd-Chiari, like congestive cardiac failure, like long-standing pericarditis that end up as chronic liver disease. In children, we happen to see a number of genetic and metabolic disorders. I'll give you a simple example of galactosemia, in which the baby is unable to metabolize galactose. present in the milk. So patient get irreversible liver cell damage as a result of galactose, ending up as galactosemia and liver failure. Similarly, hereditary fructose intolerance, because once the baby start getting sucrose, which contain fructose, and the patient may end up with a chronic liver disease due to liver cell damage. Glycogen storage disease. In certain conditions, certain types of GSD, liver is the main organ of damage. We have various amino acid disorders like tyrosinemia, and liver is damaged. We have MPS, mucopolysaccharidosis with liver cell damage. We have urea cycle disorder with liver cell damage. We have Gaucher's, Niemann-Pick disease as lipid storage disorder, ending up as liver cell disorder, chronic liver disease. We have children with Wilson disease due to copper metabolism. We have children problem with iron metabolism, Indian childhood cirrhosis, all ending up as chronic liver disease. And there are certain miscellaneous causes like cystic fibrosis and polycystic disease, and liver is again irreversibly damaged. However, it is well understood that in a large number of cases, we, especially in a developing country, we could not find out a specific, precise diagnosis because of our limitations, but patient has all features of chronic liver disease. So we have a small to large group which is idiopathic, in which cause could not be identified. So what's the definition? The basic concept of chronic liver disease means that there is progressive, ongoing, continuing liver cell damage which continues beyond an arbitrary figure of 6 months. Most patients of acute hepatitis or acute liver cell damage, they usually last between 2 to 3 months, and the upper limit has been set as 6 months. So, progressive liver cell damage extending beyond 6 months is conveniently labeled as chronic liver disease in children. Now, why it is important? Because as it progresses, it causes gradually liver cell failure, which is a terminal event. It may start as fatty liver. It may start as non-alcoholic fatty liver, and then liver cirrhosis, and there is a lot of fibrosis. It may end up as end-stage liver disease with marked decompensated liver, and then it may end up as hepatocellular cancer. But these development of cancer may be delayed for 30, 40, 50 years, and finally the patient may come to emergency as acute liver failure as a result of long-standing chronic liver disease. We use the word cirrhosis, but we should have a clear concept. What do you mean by the word cirrhosis? Now, cirrhosis is a pathologic term, but also used in clinical practice. But this implies that these are the final stages where progressive, extensive liver cell damage, all parts of liver have been involved. There is generalized, diffuse hepatocellular damage. These changes are irreversible. However, in recent days, people have come to know that if the disease can be reversed, disease process can be reversed, then in very small number of cases, the changes of cirrhosis may be reversed to some extent. But in general, this is an irreversible disease process, and essentially this is accompanied by fibrosis. There is a lot of fibrous tissues added inside the liver and also visible from outside, and then by nature there is ability of the liver cell, the remaining liver cell, to regenerate. But they regenerate cannot replicate the same original structure of the liver, but they produce nodules visible from outside, but the whole liver architecture is now destroyed. So these are the essential points in understanding the concept of liver cirrhosis. So that is how our liver looks like. I am giving you two photographs. Look at the normal liver. It is dark brown in color, a smooth surface, shining, well perfused with adequate normal standard size. Compared with the cirrhotic liver, which is small, shrunken, surface is nodular, the color is changed, it looks very firm and very different feel when you touch it. So there is a typical cirrhotic liver, and on the other hand, you are seeing the histopathology of a cirrhotic liver. You find that the normal liver cell architecture is destroyed and a lot of fibrous tissue, septa in between the liver lobules and the liver architecture. So the total blood supply of the liver is compromised. So that is all about the pathologic changes of cirrhotic of liver. Now, what are the physical signs that we observe in patients with chronic liver disease? We divide them broadly into two main types. One is the signs of poor liver cell functioning. So these are a few I have just been mentioning. The patient appears jaundiced because of bilirubin metabolism being affected. He has got a dark urine, pale stool. He has got a poor appetite. He appears lethargic. Generalized edema is there. Liver synthesizes albumin, and liver is the main site. When the liver is not functioning properly, there is always fluid accumulation because of the disturbed aldosterone mechanism. Initial stage is the hepatomegaly. Because of the liver disease going on, the liver is enlarged. But in the terminal stage, the liver is shrunken. The patient is gulped. He has got itching because of retention of the bile salts. He has got gynecomastia because of the retention of estrogen hormones. Patients start bleeding because of the liver is the main site of synthesis of many clotting factors. Patient might develop cataract, mental retardation, or tremors because of the metabolic disturbances. And final stages, when the liver is total failure, patient develops hepatic encephalopathy, which are serious neurologic disorder in association with liver failure. Now, there are signs which are typically associated with portal hypertension. You see, the liver has got dual blood supply, one from the hepatic artery, from the aorta, and the other is from the portal blood supply. The portal blood supply collects blood from the gut, stomach, gut, spleen, and then brings this blood rich with nutrients to the liver for their metabolic functioning. So, a very important blood supply for the liver tissues. And if there is portal hypertension due to fibrosis, liver damage, then these signs are obvious. Patient develops ascites. He develops splenomegaly because of the back pressure. He develops hematemesis, melena, portal cavern shunt open up, and the liver is shrunken. So these are all signs of portal hypertension in a patient of chronic liver disease. Now this simple sketch tells you what I'm talking about. Coming to you start examining patient from head to toes, and you will find all of them in different patient present together. There are signs of portal hypertension like esophageal varices, causing hematemesis. They cause various gastropathy. They might present as melena, splenomegaly because of back pressure, dilated veins in the anterior abdominal wall labeled as caput medusae, ascites, and hemorrhoids because of the varicose veins in the rectal area. Now, there are effects of liver cell damage and liver cell failure. Patient may develop drowsiness, stupor, coma. Patient may develop fetal hepaticus, which is a bad smell emanating from the patient. Spider nevi, they are simple dilated red colored venules, which are because dilated venules in the area of the posterior vena cava as a result of unmetabolized estrogens, gynecomastia with the same reason, jaundice because of the disturbed bilirubin pathway, ascites because of the low albumin level and portal hypertension, sexual characters are disturbed, testicles get atrophy, patient develops coarse tremors in the hands called liver flapping tremors. Patient may develop bleeding tendency because of the disturbed prothrombin and other clotting pathways. Patients are usually anemic. They have got a macrocytic anemia, iron deficiency anemia, blood loss, and most of them have developed edema at the level of the ankle. So all these signs are spread all over the body from head to toes. So detailed physical examination is very important. Again, some photographs showing you the stigmata of chronic liver disease. On the right side, you find patient having gynecomastia, dilated veins in the anterior abdominal wall, and of course, ascites. On the right side, on the left side, you find palmar erythema and you find white nails which are clubbed. Again, some pictures showing the stigmata of chronic liver disease, like patient having deep yellow discoloration of sclera, patient having gynecomastia, patient showing marked clubbing and white nail, leukonychia, patient having edema of the ankle, patient having dilated neck veins, patient having spider angiomas on the front of chest, palmar erythema, ascites, and very prominent protruding umbilicus. So how do we proceed further? Definitely, patient need investigation to make a proper diagnosis, and liver function test is the baseline, the first test to be performed in such cases. We have done liver function test in my previous discussion, you can refer to them, but important ones are the bilirubin, albumin, SGPT, SDOT, alkaline phosphatase, and other tests for biliary flow. Equally important is that we should do the serology of hepatitis. I mentioned that hepatitis B and C, they can progress toward chronic hepatitis. So they should be thoroughly investigated for the presence of hepatitis B or C infection in the past. Of course, CBC is a baseline test to know the level of anemia and the changed blood cells. Urine examination is important. Chest X-ray is very important. Blood sugar is very important. Renal function is very important, like urine creatinine and sodium and potassium, because they will be disturbed in chronic liver disease. Important tests related to clotting are prothrombin time, APTT, fibrinogen, thrombin, and FDP. All of them can be deranged in a patient with liver failure. Abdominal ultrasound is very important. Like the liver scan, it will have information about the liver cell surface and the presence of nodularity, uptake indicative of cirrhosis, and sometime in children, in newborn, having biliary atresia, we take help from the HIDA scan, which shows the biliary flow. We also perform the Doppler ultrasound to know the portal blood flow, decreased, direction, and the pressure and the size of the portal vein. All of them are shown by Doppler ultrasound. In metabolic disorder, we perform like the serum ceruloplasmin levels, 24-hour urinary copper levels. For Wilson disease, serum ammonia levels in patient with liver failure. Acidic fluid is frequently used to know its composition, like the protein content, sugar content, cell content, and others, and LDH levels. In patient having autoimmune hepatitis, we go for investigation like anti-nuclear antibody, anti-smooth muscle antibody, anti-liver kidney microsomal antibody, and sometimes Coombs test. However, in number of cases, the final diagnosis is made by liver biopsy, which is attempted in these children as well. How do we manage these children of chronic liver disease? The first thing is we must educate the parents and the family, because the disease has to stay. It continues for decades, for years, not going to be totally, may not be totally recovering. So we have to medically educate the parents and the family on the management issues. And we impress on them the importance of regular follow-up. These patients, of course, when the liver is compromised, they need adequate rest, because under stress, very difficult for the disease to come to a basal level. Avoid any type of stress, like infection, like fever, like exertion, because they will further compromise the liver functioning. Diet, yes, we need to give them good diet, high calorie for the liver regeneration to take place, with optimum intake of carbohydrates, because we have to maintain the blood glucose levels. Liver is the main organ which maintains blood glucose level, and we need to give them good source of glucose as well. We should give them good protein intake, but again, when the patient has got advanced liver disease with liver failure, the protein has to be reduced, because they will add further to the nitrogenous waste product. They should be of good quality. When the liver failure, definitely fat absorption is compromised, so metabolism is affected, so we need to reduce the amount of fat intake. But we must add adequate amount of micronutrients like vitamins, minerals, like fat cell vitamin and water cell vitamin for adequate liver functioning. Always avoid hepatotoxic drugs in patients with chronic liver failure, like paracetamol, like anti-tuberculous drugs, like anti-epileptic drugs, and many other drugs which are now taken as hepatotoxic, so they should be avoided. We must protect our children and adults with hepatitis B vaccination, which is available, simple, cheap, and affordable. So we should avoid another problem because of hepatitis B infection in these children. Of course, there should be salt restriction and fluid retention if the patient has signs of fluid retention, so the salt should be minimized. Many of these children, when they develop ascites or edema, they are benefited by use of diuretic like Lasix and spironolactone with aldosterone antagonist on a long-term basis. The abdominal paracentesis is very frequently done in these children because they have ascites, which is compromising their quality of life and compromising their respiratory activity. On the right side, you find a child with marked ascites and marked distended abdominal veins. This child needed abdominal paracentesis, and on the other side, you find that the fluid is being withdrawn under aseptic conditions. Of course, we should take due precaution that the needle should not enter the bladder and it should not enter the intestine, and then should take out fluid. This is for diagnostic purposes as well as for therapeutic purposes. Now, what is the drug treatment of chronic hepatitis? Of course, the treatment would depend on the underlying disease causing chronic liver disease. You can't have just one treatment for all conditions. Say, if the patient has autoimmune hepatitis, then the patient is benefited by using of steroids like prednisone on daily basis, and sometime with the addition of immunosuppressant like azathioprine. Patient has a metabolic problem like galactosemia, he will be greatly benefited by use of a galactose-free milk. Patient having Wilson disease with lot of copper disturbances in the body, inborn metabolic errors, so we use chelation therapy for copper in the form of regular oral penicillamine. Patient having metabolic disorder like tyrosinemia will be benefited by use of special milk formula in which that particular offending amino acid is removed. There are just few examples. Patient has biliary atresia. In that case, we need to refer to surgeon because the surgeon will operate on these children and they will perform a biliary drainage surgery, because when there is no then there is congenital absence of common bile duct, gallbladder, and the biliary drainage system will need to operate so that a biliary drainage operation is being done. This is called Kasai operation, and if done timely, can be life-saving. Patient with hepatitis B, chronic hepatitis B, they will get benefit by use of interferon alpha and lamivudine. These are two standard drugs which are utilized in patients having chronic hepatitis B. For chronic hepatitis C, we are using pegylated interferon and ribavirin for children below 12 years of age. Nowadays, newer drugs which are called direct acting antiviral drug like Sofosbuvir, Sovaldi has been recommended and available in Pakistan. It is given for a 3-month course and it almost ends as complete viral elimination from the affected patient. However, these drugs are not recommended in young children. Usually the age is around after 12 years. And of course, if the patient needs therapy, we should refer them to experts in the field. Now, again, what drugs are required in these children? I have given you a list. For hemostasis, because of the bleeding from the varices, we frequently require vasopressin to control bleeding from the stomach and the esophagus. To decreasing portal venous pressure, we require beta blocker like epopronolol. Patients who develop hepatic encephalopathy or in the pre-coma phases, they will benefit by use of lactulose because that will trap ammonia, acidify stools, and patients' encephalopathy can be improved. Sometime we were using to change the bacterial flora, to eliminate bacterial flora, we were using neomycin, but it is now not much in use. Gastric acidity can be lowered by the use of cimetidine. Patient having fluid retention can benefit it by diuretics like spironolactone and Lasix, furosemide. And When there are clotting disturbances, they may benefit by use of vitamin K and plasma. When there is portal hypertension, now you try to understand that when there is a lot of fibrosis, then the portal vein, hepatic vein, and the sinusoid, all of them, they are compressed in the fibrotic tissue. Ultimately, that ends as obstruction of the portal venous blood flow. The blood pressure in the portal system rises. It's called portal hypertension. As a result of the back pressure, the venous pressure rises. There is splenomegaly, is all because of the congestion. The collateral circulation between portal and the systemic circulation, they open up, and the patient might bleed from the dilated esophageal varices. The esophageal varices is a dreaded complication in such cases, and the answer to that is reduced portal hypertension. Bring down the very high portal venous pressure to near normal levels. The reason being that there is opening up of the collateral channels in the lower esophagus, anterior abdominal wall, in the palatus peritoneum, and the rectum, in which the communication channels are anatomically present between portal circulation and the systemic circulation. So these veins ultimately become varicosities. So they may bleed, ending up as esophageal and the gastric varices, caput medusae, and the hemorrhoids. All these clinical problems are frequently seen in these patients. Now, what's the final answer to that? Liver transplantation in children is now an established therapy. It has been done at a number of centers which specialize in liver transplantation, and good centers are reporting a 5-year survival as high as 85 to 90%. Now, who are the candidates? First are those candidates who are very unfortunate. They develop acute liver failure. They got simple attack of hepatitis or some toxin or some chemical, and they develop acute liver failure. Then patients who are biliary atresia, they are benefited. Patient having Wilson disease, metabolic liver disease, polycystic liver disease, or end-stage liver disease, all of them have benefited from the liver transplantation. Now, who is the donor? Either it is a dead person, close to death, diseased donor graft, or a living related donor who gives them a liver transplant. So both are working. And of course, please understand that this is now a very complicated issue, and this needs a formal approval from the transplant authority made in Punjab, named as Punjab Human Organ Transplant Authority, which gives an official permission for these cases. In Pakistan, the liver transplant is not very common, but there are cases which have been done, and especially one big institution is Pakistan Kidney Liver Institute in Lahore, which is still in the process of development, but they have started doing it at a smaller scale. Now, coming to the topic of liver failure. Liver failure is the end-stage liver disease once there is severe hepatocyte dysfunction. The liver is totally compromised. So these may present as either acute liver failure, that is, patient just has got a small, very short history of liver disease of less than 8 weeks, but without any previous history of liver disease, and then suddenly ends at liver failure. Or sometimes patient has chronic liver disease for many, many decades and years, and then suddenly he becomes victim of acute liver failure. The two main features are that patient develop encephalopathy. They become drowsy, they develop comatose, they develop convulsions, they develop brain edema. So they are features of hepatic encephalopathy. And many of time they start bleeding as well. Liver being a vital organ, liver synthesizes all clotting factors. So that becomes a very important sign of liver failure, that is the patient starts bleeding from everywhere. In the terminal stages, patient develops multi-organ failure. All important viscera start failing, like kidneys fail, called hepatorenal syndrome. Lungs fail, GIT fails, CVS fails, and there is problem of encephalopathy and hemostasis. This carries a very high mortality. Now, the basic thing is that hepatic encephalopathy ensues because in the intestine, various amino acids are being deaminated by the bacteria and the enzymes. Now that ammonia level usually goes to the liver where it is converted into urea. But once the ammonia goes through the blood into the liver and there is no liver detoxification, this high ammonia level will reach the blood, and then the blood-brain barrier will cross the blood-brain barrier and ultimately cause encephalopathy. There are other toxic products other than ammonia which are all involved in it. It's not only the ammonia, but many others are also involved. So a patient either becomes euphoric, irritable, confused, develop a speech problem, develops a breathing problem, develop hyperreflexia, and positive Babinski, he developed flapping tremors of the hand, develop a very bad foul breath, and ultimately become deeply comatose. All of them are features of hepatic encephalopathy. Now coming to awareness part, the preventive part. We have mentioned the problem. It is around 15 million people in Pakistan have been suffering from features of chronic hepatitis. So we must make this a very important media awareness campaign on the print media, electronic media, digital media, and then we should propagate, promote the message about the various health centers all over the country, in the schools, about how to prevent hepatitis from developing in any one of us. So one thing is public awareness. The second point is that there should be a universal hepatitis B vaccination to prevent hepatitis B. There must be a birth dose along with BCG, and then the usual vaccination is given at 6 weeks, 10 weeks, 14 weeks. We must vaccinate and check all health care professionals, all high-risk professions. We must go and check them. If they are not immunized, we must immunize them. We must screen, because I said that there is very important cause of maternal, neonatal transmission of hepatitis B and C. So we must check all pregnant mothers for hepatitis B. We must screen all healthcare workers, doctors, nurses, paramedics, sweepers, everybody in the healthcare environment should have a hepatitis B exposure, and he must be checked, because then we want to do the early detection of carriers. We must screen all the blood donors, professional blood donors, non-professional blood donors, and all the blood and blood products for Hep B and C, because we want to check the transmission. We must use disposable needles without any reuse. We should minimize pricks by all health workers. We must promote that all invasive equipment should be completely sterilized by autoclaving, and we should promote use of disposables in all healthcare institutions. Just one-time use, no second time, no reuse. Now this should apply to all hospitals, all maternities, all dental setups, all where their local barbers, which are doing circumcision, which are doing tattooing, they should practice these important steps. There are so many barbers who are sharing razors among the different customers. They are using same instrument for circumcision without getting autoclaved. So there is a transmission of disease from one person to the next person. There are so many dental practitioners which are reusing the same equipment again and again. There are so many drug addicts who are sharing needles for IV among each other. But again, there should be facility for proper diagnosis of hepatitis B and C at all government level institutions, which is affordable, and then the treatment of hepatitis cases should be available at all government institutions. These are some of the steps which have been shown how this can be prevented. First, the message that about 1 crore people in Pakistan are infected by the hepatitis viruses. Now the figure has risen to 15 million. Second, it tells us that regarding syringes, always use disposable syringes which are never to be reused. Next, people are very habit of getting tattooing, in which the same needle is used among different customers. So tattooing is a very important risk, and either it should be avoided or we must practice the safe needles, unused, single use. Again, every mother should have hepatitis B status checked and protected. Protect the next generation by giving them hepatitis B vaccination immediately after birth. Then most of the dental procedures should be done hygienically, and the equipment should be very sterile and not used in different patients with the same needles and the same dental equipment. The personal equipment से जैसे सेफ्टी रेजर है, टूथब्रश है, मिसवॉक है, नेल फाइलिंग है, नाखूनों की कैंची है, all of them are very important source of transmission from one infected person to the next person, so they should be avoided totally. Well, the government realized the situation. As a doctor, we should know that the Prime Minister Hepatitis Prevention Program was started in year 2005, because that was considered, that ultimately came to the attention of the political circle by the government of Pakistan, and they launched a Prime Minister Hepatitis Prevention Program back in year 2005. And the government announced that 61 centers all over Pakistan, they would be given the responsibility of diagnosis, that is by use of the lab investigations, and treatment for these patients from the government hospital. However, ultimately it gradually was not properly supported after 5 years, and then again it was relaunched in 2019. The new government again relaunched the same program, that is providing them facilities for diagnosis and treatment for chronic hepatitis cases. And ultimately, the year 2030, that was set target for the campaign for elimination of hepatitis in Pakistan. The target set was that there should be a 90% reduction in the incidence and a 65% reduction in the mortality of chronic hepatitis. And We know that there are 15 million cases of hepatitis. At this moment, they are prevalent. Among the new cases, which are called incidence, something like 2 lakh cases, that is 200,000 new cases are seen every year. And they're added to the already present 15 million. And we all know that almost 10% of the Pakistani population somehow is exposed to hepatitis. They can be labeled as carriers in a rough way. So we all should work hard for a hepatitis-free Pakistan. Thank you very much for your very patient listening.